Thank you very much, Pete. As I tried to get the podium up here a little bit, I'll just remind Rowan that in our household it's the husband that takes the dog for a walk, and I'm not sure whether that will work. So I'm charged, and thank the invitation to speak about sex hormones and breast cancer risk and prognosis. I'm actually not going to say very much directly about prognosis because so little data actually exists, somewhat surprisingly. I would say quite a few things that relate to prognosis, however. The things I'm going to cover are to talk about risk factors for breast cancer, particularly in terms of postmenopausal, and then onto a little bit of premenopausal, then talk about something which I think of as an intermediate phenotype for gene studies. I'll explain what I mean by that. I'll talk about its importance in established breast cancer, looking at postmenopausal estrogens with gene expression, the menstrual cycle and how that might affect gene expression. A few words about monitoring for AIs in chemo-induced amenorrhea, and then a few words on obesity and aromatase inhibitors. And lastly, and perhaps most importantly, talk about the measurement and I think mismeasurement of these sex hormones. Most of what I'm going to discuss relates to estrogens. I will say a few words about androgens, but in the main, the data relate to estrogens. So in the area of quite complex molecular pathways, networks, etc., it's refreshing to look back on the sex steroid pathway here. Clearly, the aromatase gene is a fundamentally important enzyme, I should say, in both reproductive physiology and in breast cancer, in that it converts androgens through to estrogens. Oestradiol is the most biologically active estrogen, but estrone has some influence. Estrone sulfate is not an active estrogen itself, and its main role for us, and what I'm going to talk about today anyway, is to act as a surrogate for the primary estrogens, given its much higher levels and ease of measurement. The influences on aromatase obviously vary through the woman's life. In premenopausal women, the ovaries are by far the richest source of estrogen, with cyclical changes throughout that. In postmenopausal women, the ovaries are devoid of aromatase, and indeed that's responsible for the menopause. But aromatase continues to exist in subcutaneous fat, and estrogen levels fall by about 10 to 20-fold. There is some estrogen synthesis in normal breast and in breast tumors, but the particular importance of that still after 40 years is not as clear as we would like it to be. Sex hormone binding globulin also plays a role in some of the things I'm going to talk about. SHBG binds avidly to testosterone and estradiol, such that only 1 to 2% of these estrogens and androgens are actually circulating free of protein and are biologically active, and we will talk about the influence of that in some of these circumstances. Now, the data really became convincing about these hormones being related to the risk of breast cancer just over a decade ago now, when Tim Key organized the group of the Endogenous Hormones Breast Cancer Collaborative Group, and these 9 studies coming together and looking at the risk of breast cancer according to the quintile of hormone level. I'm showing the estradiol and estrone level there. You can see the chi-squared up here. If my pen works, yes, of 22.26%, anything with a chi-squared above 3 will be significant. And you can see, therefore, that there is a strong trend to estradiol, the top quintile having about double the risk of breast cancer in these postmenopausal women compared to the lowest quintile. For estrone, it's similar. For testosterone and androstenedione, it's similar as well. But if you do a multivariate analysis, the importance of the androgens is reduced markedly. And it seems that their presence largely, but not entirely, is present in this relationship by virtue of them acting as substrate for estrone and estradiol. SHBG at the bottom there, as you can see, has a weak but negative association, as you might expect, given that it binds and reduces the activity of the steroids. Now, very recently, the data from the Nurses' House study was updated in the postmenopausal women. And across here, you can see that this is one of the biggest studies. It contributes a great deal to what I've already shown you. Looking at the overall set in here, you can see that there is a relatively smooth and increase in risk of breast cancer across the board for invasive breast cancer from 1.0 to 2.1, now in quartiles rather than quintiles. Looking at the ER negative group, PGR negative, there is no increase in risk. Some, not surprisingly, consistent with our thinking. increased estrogen would not increase the risk of an estrogen receptor negative tumor. The risk, in fact, is much greater. The relationship is much stronger for ER positive, PGR positive, with a gradient there from 1.0 to 2.8. You may have seen on that previous slide that I stated that these are all based on just single measures of plasma estrogen in that particular postmenopausal woman. If you do repeated measures, you do improve the amount of information, and if we were to get better methodology, and I'll come back towards the end, we're likely to see even greater and more substantial risk relationships. Now, thinking then about this group of ER positive, PGR positive as our sort of endpoint here, I've taken really, I think, the strongest set of data, again from the Nurses' House study, but this is NHS2, looking at premenopausal women. There are far fewer data, and the situation is less convincing about premenopausal hormone levels being related to risk. This study looked at this in both the follicular phase and the luteal phase. Looking at total estradiol in the follicular phase, you can see there is a trend towards a relationship, which wasn't statistically significant. But if we now look at free estradiol, this was calculated from the SHBG estradiol ratio, there is now a highly significant relationship. But measurement in the luteal phase did not relate to risk. But it does appear that exposure to estrogen, the free estrogen in particular, does play some role in the risk of breast cancer in premenopausal women. Of course, because of those cyclical changes, it's much more difficult to measure. Now, actually, I think it's Force and Gallen meetings ago, a small meeting was held down at the Einstein Hotel, chaired by Dick Santon, and a publication resulted from this, which talked about the different factors we might bring to bear to allow personalized risk reduction strategies, to identify the risk in individuals and talk about what one might do in those individuals. And you can see third on the list there, the measurement of free estradiol was actually suggested. In the more recent past, and Judy will say a lot more about this, of course, gene profiles have come through that we might consider as integrating into this. Really, to bring this to fruition, I think we need comprehensive studies of large size which actually measure all of these features and allow us to see the interaction between them. We have one in the UK at the moment called the Breakthrough Generation Study that will start reporting this year. It's in 115,000 women, and actually it plans a 40-year follow-up. The other thing that we definitely need, and again I'll get back to this at the very end, is we need better estradiol assays to bring this to reality. I'll now move on to looking at sex steroids as an intermediate phenotype in relation to identifying genes associated with breast cancer risk. This is essentially saying most of the time we're looking at a gene and how this relates to risk of breast cancer, and we do these very large genome-wide association studies for this. And the concept is that the link between the sex steroids and breast cancer is now substantial enough for us to look at the relationship between the gene and the steroid level, which needs many fewer patients. We reported actually nearly a decade ago one of the first studies of this type where we looked at the CYP19, the aromatase gene, and looked to see whether that related to the ratio between estradiol and testosterone. Indeed, there is a SNP there, you can see on the left-hand side, which relates the genotype relating to the level of estradiol when normalized for testosterone, and similarly for SHBG. So it is possible to identify these relationships. There are genes which do influence plasma steroid levels. A couple of studies here in the more recent past, I'll just mention a couple of words. These are a very wordy slide, unfortunately. The top one there is published just last year in Journal Lancet JNCI, and this was actually in premenopausal women, looking at urinary estrogen and, in fact, estrogen glucuronide levels, which were found to be 21.8% lower in patients with a SNP in the CYP3A gene cluster. And indeed, that then did lead for an investigation of that particular SNP in relation to breast cancer and revealed that this related to a lower risk of breast cancer in those women before the age of 50. That was therefore a successful exploitation of this methodology. A more recent GWAS did not actually reveal anything that we didn't know already. Moving on then to thinking about breast cancer itself, and the thought that plasma estradiol levels might influence gene expression in estrogen receptor positive breast cancer. We published these data, 3 years ago now in JCO, where we'd looked using a 48,000 gene chip, which actually reveals, that's 48,000 transcripts, actually reveals all the 25,000 genes, the expression of those genes in about 100 estrogen receptor positive breast cancer. And we said, how do the specific genes actually relate in their expression to plasma estradiol levels? And I was actually astonished to find the top gene when we ranked these was TFF1, that's PS2. It's very well known to be an estrogen responsive gene. And then these other genes, I've listed just 7 there, GREB1, RAGE, etc. PGR there at number 85, out of 25,000, I'll remind you, genes, actually have these strong relationships with plasma estradiol in these estrogen receptor positive tumors. And if we actually bring 4 of these together, we selected TFF1, GREB1, PDZK1, and PGR because they've got strong evidence in vitro studies as well into something we call the AVERG, the average of the estrogen-regulated genes. If you plot these against the log of estradiol, you get an R value of 0.5 shown there. And in fact, if you then say, well, what about if we bring estrogen receptor levels into this and look at that in, as well as plasma estradiol, how does that predict for the regulation, or I can't really say regulation, the association with the expression of these 4 genes? You get an R value there of 0.61. I find this quite striking when we talk about the heterogeneity and the molecular heterogeneity of this estrogen receptor positive subset, that plasma estradiol and estrogen receptor themselves have such a dominant effect. And perhaps most markedly, that is 27% of that relationship was explained by estradiol and 10% less, substantially less, by estrogen receptor itself. And indeed, if we look at the progesterone receptor status of these tumors and say, how does the plasma estradiol relate to whether a tumor is PR positive or PR negative in that patient, you can see that the median level there is 35 picomoles per liter on the right-hand side, the PGR positive, versus 23 in the PGR negative. Now, of course, we don't know whether that's cause or effect. Is it that we've caused the patients to actually have PGR positive tumors, or it's been caused by those higher estrogen levels, and that relates back to the risk aspect of this? Or in these patients with established breast cancer, is it a regulation of that gene accorded? And it's probably a mix of the two. So more recently, we've asked whether or not some of this estrogen-dependent gene expression varies across the menstrual cycle. And we collaborated with colleagues in Milan, particularly Beppe Vialli, and did this study, which has just been published, in 170 estrogen receptor positive premenopausal patients who had very careful recording of their menstrual cycle, including 3 sequential progesterone levels to see whether the levels were going up or down. We divided prospectively, before we looked at the data, into 3 windows. Window 1 was in fact the start and end of the menstrual cycle with low unopposed estrogen levels. Window 2, high-ish unopposed estrogen levels. And then window 3, these medium estrogen levels where you have unopposed being progesterone now coming in the luteal phase. And we had just around between 50 and 60 patients in each of those windows. So these are the data here. Looking at the left-hand panel there, the estrogen receptor gene expression itself doesn't vary or didn't vary across the menstrual cycle. Each of the 4 genes I've been talking about there, PDZK1, GREB1, PGR, and TFF1, all show some relationship, with the highest value here being in that middle of the section, the unopposed high estrogen level, with PGR levels and TFF1 levels actually being about double that which they are at the start of the follicular phase. So there does seem to be some regulation of these estrogen-regulated genes through the menstrual cycle. I have to stress this is not a longitudinal study. This is a cross-sectional study, so these are different women. We're currently doing a longitudinal study, but I think it's sort of sobering to think that when we do all these gene profiling studies, this is the sort of thing we don't really take account of, and it may be important to do so. So if we're measuring gene expression profiles involving estrogen-regulated genes, one should at least consider the potential influence of the menstrual cycle. Now, just a few words on estrogen suppression with aromatase inhibitors and body mass index. Evidence has emerged, published in JCO again in both cases, from the ATTACK trial and the ABCSG12 study, that the relative benefit, and I stress relative benefit, from AI versus tamoxifen is less in patients with high BMI. The focus has actually been in people investigating, therefore, whether the aromatase inhibitors might be less effective in these women where there is more of the target, the high BMI, the high subcutaneous fat, the high aromatase level. One could consider, of course, whether the reverse is the case with tamoxifen. Is that actually more effective in those high BMI? But I'm going to focus on the first of the questions. And the data we drew on were from the ALIQUOT study, which we did in collaboration with Mike Dixon. ALIQUOT was a study of 6 months where patients were randomized to receive 2 aromatase inhibitors sequentially, anastrozole or letrozole, in a randomized crossover sense. So they received anastrozole for 3 months, then followed by letrozole for 3 months, or the reverse. And you can see there is very substantial, very consistent estrogen suppression using this very sensitive assay. The limit of quantitation there is 3 picomoles per liter, which is about 1 picogram per mil. And you can see with letrozole, only 1 out of 54 patients had a value above the sensitivity limit. We drew on these data to say, well, how did BMI, or did BMI, affect this suppression? These are the data. So they were published in JCO last year. The top panel here is Oestradiol. And you can see in the pre-treatment situation, we have the expected relationship. And it just shows you the strength of the relationship between BMI and plasma estradiol levels, going from 20 in patients with a BMI of less than 25 up to 55 picomoles per liter in these heavier patients. And this is just as clear, if not clearer, in estrogen sulfate, which, as I say, has got those higher levels. Strikingly, we continue to see that relationship with anastrozole and indeed with letrozole in both circumstances, increase in levels of the estrogens with high BMI on the aromatase inhibitor. Now, the degree of suppression is actually very similar between these patients. The residual levels are higher in the heavier patients. Letrozole remains more, gives you a more complete suppression in all cases. So the relationship, and this is a potential explanation for the lesser relative benefit from the aromatase inhibitors, isn't absolutely clear from this. But for sure, it would be nice to be able to get push those estrogen levels down and completely ablate the estrogen if we possibly can for the greater efficacy that we're likely to get in these patients. We'll be able to study this in much greater detail and intend to do so in the FACE trial, where patients are being randomized between anastrozole and letrozole, and again, we're measuring estrogen levels at the very moment. Monitoring estradiol suppression. So Matt Ellis showed you some data yesterday where he published in Nature just a few months back gene mutation analyses from a clinical trial, with Ki67 being one of the endpoints. And of course, Ki67 is increasingly being used as an endpoint in neoadjuvant studies. One of the things we see, and I've highlighted there, just 6-7 patients who've shown relatively poor suppression of Ki67. It's a modest number. We'd say about 20% of patients will be identifiable of that type. Most show very good suppression. And we select those out as a sort of what we call a bookend study. Patients showing particularly poor suppression, and we focus in on those to say, well, what's the explanation? Well, one explanation we need to exclude is that they didn't take the drug. That's trivial. We don't want to be doing next-generation sequencing to try to explain something is because of poor compliance. In a study called POETIC, where we now have 4,000 patients of this type, we've started to explore next-generation sequencing for this type of analysis. And we found that about 15% of those poor responders had no estrogen suppression. Now, I can't say for sure that that was due to poor compliance, but I can say that it's not likely to then have a genetic explanation. The poor estrogen suppression is likely to be the explanation. I do think we need to bear this in mind when we're focusing on that particular small population. Some years ago, Ian Smith presented data and coordinated a group of us, creating a cautionary set of guidelines where we talked about the fact that women with chemotherapy-induced amenorrhea that then go on to aromatase inhibitors because they're apparently postmenopausal showed increase in estrogen levels, increased return of menses, and indeed occasional pregnancy. Those guidelines, I think, still exist and remain pretty much unaltered. There have been recent publications, not by a gentleman that's got 4 R's in his name, but it's got 2 R's and an E, followed by another R. Another one where we were hoping that something like anterior Mullerian hormone, AMH, might actually be a help in identifying the residual ovarian follicular levels. It really doesn't help at all. It did not exclude residual ovarian function in patients who are on aromatase inhibitor if undetectable. So we're still in a position where to actually assess these patients, we need to continue to monitor estrogen. So just in my last 2 or 3 slides then, I'm going to talk about the analytical methods that have underpinned everything I've talked to you about so far. Now, we've had in our laboratory an assay which has been in place for something like 25 years, pretty much unaltered. It's a highly sensitive assay. I've shown you data from the ALIQUOT study, and I just show you the comparison here between the performance of that assay, where you can see in the blue the pre-treatment levels of 10 patients here, the plasma Oestradiol levels, and then the sort of purple level at the bottom, their suppressed level. Using a routine autoanalyzer method, which will be present in my hospital and other hospitals, you can see we have much higher levels to start with. There is a decrement when we add the aromatase inhibitor in, but it's nothing like as great, and you can see the residual levels look higher even than we find in our untreated patients. Why should I think ours is a more reliable method? Well, we show good correlation with GCMS, and in a more recent publication, some 6 years ago, with Jennifer Lee, we look at the Marsden assay versus another mass spec assay here, and again, you can see the R value is as good as 0.89, but in another, what's called a direct assay, where we don't extract the estrogen, the R value goes down to 0.65. Essentially, many of these assays are really not fit for purpose if we apply them to postmenopausal women treated with an aromatase inhibitor. The questions I would ask you to ask yourself, if you're thinking about doing a study, if you're thinking about measuring estrogens in aromatase inhibitor treated patients, or indeed if you're thinking about interpreting the data from published studies, ask, is the assay sensitive enough? Is the assay specific enough? And there are, for example, cross-reactions with exemestane. Most assays cross-react with that. There are matrix effects, and these actually affect tandem mass spec studies. Essentially, is the assay fit for this purpose? Ask yourself that when you actually evaluate the data. The dreadful thing for us is that the rabbit that we have the antibody from, that we've been using for 25 years, actually died in 1990. And the antibody is now effectively completely gone. We've searched the world and have been trying for some 2 years now to come up with an alternative assay. We don't actually have one. We now feel that to do reliable studies in this area, we do need to go to GC tandem mass spec, but I would suggest we still need to evaluate these with great care. So just a few concluding remarks. Measurement of plasma estrogens and androgens continues to have major importance in ER-positive breast cancer research. It has potential use in breast cancer risk profiling, but we need better assays. We continue to have this established need to monitor in chemo-induced amenorrhea, but we need better assays. And there is a lack of and great need for widely available, valid assays for the assessment of plasma Oestradiol in postmenopausal women with or without aromatase inhibitors. Thank you very much.
Thank you very much, Mitch. We're going to take questions at the end.